Conference room number accepted. If you are the organizer, press the star key now. Otherwise, please hold. This line is now muted. This conference will now be recorded. For a menu of available commands, press star 1. There are 15 participants in the conference.
Fully grown gross revenue and net reimbursement through combining operational improvements, charge master effectiveness, and efficient business office protocols. John earned his bachelor's degree in business administration and political science from Boston University and his master's in public health administration from Suffolk University. Now I'll turn it over to John.
Well, thank you very much, Kim. I appreciate the introduction, and I appreciate you being able to provide a platform to get these types of topics out to your constituency. It is a very useful and well-timed topic for us to discuss today. So I want to welcome everybody that is on the line. I very much appreciate you taking some time out of your busy schedules to discuss something that is, at the tips of everyone's tongues, but often it's something that we don't really want to talk about, because when we start talking about prices, especially in a hospital situation or in a physician clinic, it's uneasy. There's opportunities where, expectations are all over the place, understanding of where we are and how we got here. People have different understandings and don't necessarily at times know what to say and can't communicate things to people. So what we want to do today is we want to walk through and really bring to you a lot of the results of working with our clients over the last, 5 to 10 years, what we found useful in trying to go and move ourselves to a controlled pricing thought process that will allow it to not only meet the needs of the organization, but also meet the needs of our customers, because our customers really are more educated than ever. So we need to always keep them in our mind. So what we're going to do today is we're going to walk through this, and the way we've designed it is there's, about 7, 8, 9, 10 steps that we think that there's considerations that you really need to pay attention to. So my goal is with each of these considerations to kind of talk a little bit about them, then provide you an action item or two so that you can then take this and regardless of where you might be on your revenue cycle journey, in how you've developed your pricing strategy, if you've got one that's really clicking and working well, or you're just kind of starting with it, the action items are designed to help provoke some communication, some thought in your overall process and make it so that you can take substantial incremental action towards that goal that you're setting. So with that, why don't we get going here and start talking about things. So what are the expectations out there? It's amazing right now. So transparency and pricing requirements and customer expectations are on the rise all over the place. You see things in articles, you see things in national publications. I'm sure that even to the level of your radiology techs, your physical therapists, your registration staff, they're getting questions nowadays that they've never been exposed to. It's all about, what is this going to cost me? I have a $5,000, a $7,500, a $10,000 deductible. What's going to happen with this? And what patients are doing is they have an expectation that whoever they ask in your facility, they're going to be able to get that information back into a digestible and usable format. And oftentimes, we're not able to do that. So in the media, and along with the payers, they're routinely publishing fee comparisons for regional competitors. So you see that a lot nowadays. So that's not a bad thing because, when published information gets out there, it really does nurture a more informed public who, in turn, can really start placing new demands on the providers, but a lot of times those are appropriate demands. It's not unreasonable for a patient to show up at your facility, ask for a service that they're going to be provided, and just say, how much is this going to cost, and have the people that they're asking provide that information, and then will be that when they get their bill, it's actually the amount that you quoted. That's not a stretch anymore. So high deductibles and increased coinsurance responsibilities have driven dramatic increases in patient inquiries into internal pricing methodologies. So if you are not aware of those conversations, I promise you that they're happening. And what we want to talk about here today is, as we're going along, is, how do we exceed the expectations of our patients and make sure that we're doing the things that we need to, so when they ask those questions, we're raising their confidence levels. So how do we do this? How do we, whenever I talk about pricing, I really want to make sure that we're focusing on the right thing. So I always refer to our pricing methodology as a patient-centric and defensible pricing strategy. So we are keeping our patients in mind, and at the same time, it's not only what we're doing them, but by keeping our patients in mind too, we're working on making sure that the financial viability of the organization is ensured. Because we want to make sure that, that each facility, whether it's the doctor's practice, the critical access health, whatever it might be, you have a large responsibility to the community, and part of that is to make sure that we do everything on the business side to make sure that we're viable and we're meeting the needs of the groups. So when questions start coming in, many providers struggle to explain or understand the methodology used to establish pricing. You get a lot of, I don't know, it is what it is. That gets set by administration. I don't actually know who sets the prices. You would know better than me. You get the bill. I don't even have a clue. That's not something that I worry about. I'm just the nurse. I'm just the radiology tech. And at that point in time, the poor patient who's already nervous about going through all of the services that they're there for, they're now even more concerned because they don't know how much this is going to pay. And they're looking at this saying, man, this is going to cost me cash. So this lack of clarity and consistency prohibits best-class customer service. It really gets in the way because the patients are vulnerable, but they just want to know. They want to feel that they're in a situation where there's controls in place. So remember, if you've ever been on any of my webinars, I always work to make sure that we look at things from a quality standpoint and we say, from a clinical standpoint, we are 0% defects. From a business office or business or revenue cycle, however you want to call it, that still has to have a 0% defect mentality, and that's what should be driving your customer service. A lot of your contracts as well, when you start looking at it, have lesser of language in the contracts that really make it so that if our pricing is all over the place, we may be limiting our financial viability. So a patient-centric defensible pricing methodology is an absolute requirement for appropriate reimbursement, representative budgets, and best-class customer service. So that's what we're going to be working on to talk a little bit about today. So why do we care? I get this all the time, whether it's from the big institutions, the critical access. So why am I worried about pricing? I'm paid by fee schedule. I'm, critical, I paid by this, that, and the other thing. Well, implementation of a controlled pricing methodology will contribute to increased gross revenue, improved customer service, and more consistent account adjudication. So if you look at it, we want to eliminate variability everywhere. Clinically, that's everything we do. All of our policies and procedures on the clinical standpoint are geared at eliminating variability. It should be the same process on our business side as well. So one of the areas that variability really causes a lot of concerns is in our pricing. So to hit it home a little bit, so we recently did 4 large critical access hospitals in the same state, okay, and we went through a full pricing analysis, okay, and we really went through and did a lot of the things that we're going to talk about here in a couple of minutes, okay. So we looked at it, and in total, there were 57 departments across the 4 hospitals that were looked at, okay, and these all had payable CPTs in all of those departments, okay. So of the 57 departments, 32 or 56% of the departments included codes that had prices set lower than what Medicare had set for their fee schedule. An additional 16 of them, or 28%, included prices that were set lower than 2 times Medicare reimbursement. So as we started talking to the hospitals about their costs of providing those services, all of a sudden they looked at it and said, well, I don't have any service that I provide in this hospital that really is less than 2 times Medicare. My costs are much higher. So now we've got an imbalance in these hospitals. Additionally, there were 35 departments, or 61%, that included prices that were set higher than 5 times Medicare reimbursement. So if you can think about it, in some of these departments, they had prices that were set as low as, 0.25, so a quarter of what Medicare would pay, and in some of them as high as 18 times what Medicare would pay. So there is a wide range. So if you're looking at it and you're a patient coming through and you're expecting consistency, there isn't any in there. If you're setting up your budgets, there's no consistency there. So the CEOs and the CEOs were flabbergasted because they thought that they had this in control. Clearly they didn't. So how do we do this? Okay, so let's start getting into this a little bit. Okay, so first off, okay, and again, regardless of where you are in your journey, whether you got this nailed or you're just starting out, each of these areas of conversation and consideration are really things that we're looking to maybe just check off, say, you know what, we've got this, we did this really well, or this is a good place for us to start. Okay, so first things first, you just start with the end in mind, but evaluate the baseline comparison fee structure. So what are you? Where are you? Okay, so one of the things that we suggest is that Medicare does a great job publishing information. Okay, they get you what they're going to pay, and quite frankly, their thought process and their methodology is really good. In a lot of cases, if you look at Medicare APC, the way that they put those fees together are really all of the components that a critical access hospital really cares about. So it's a terrific, useful, and meaningful area to use. So one of the things that we look to do is go through and compare, find those Medicare fee schedules, and compare them against where we are. Okay? So what that does is that if we have a procedure that we are charging $100 for, okay, and we look up the Medicare fee schedule, whether it's Part B, Lab, APC, whatever it might be, and we find out that they pay $25 for that, okay, de facto, whether it was intentional or unintentional, okay, we've marked that procedure code up 4 times of what Medicare would pay. So if we start doing this for an entire department, you start getting the range. And this is what happened with those 4 critical access hospitals. Now they started seeing that in those departments, they had all these codes that were set lower than Medicare. So in the example that I just gave you, for the charge that was out there for $25, they were charging $18. And then conversely, on some of them, instead of $100, they were charging $1,000. Why? Because they made a fat-fingered 0 instead of a decimal. Okay? So an action step, evaluate your current CDM pricing against the most appropriate Medicare fee schedule and prepare to research significant variances. Okay? So obviously we're not trying to set things lower than Medicare, and you don't want any prices set higher than 17. But what we want to make sure of is that you establish a pattern and understand in reality what you are. Very good first step. Where possible, and again, everything that we're talking about here in this pricing methodology, one point that I really want to bring home, it is critical, regardless of what revenue cycle component you're looking at, charge master, revenue capture, compliance, whatever it is. You don't look at these things with blinders on. You look at these areas of concern with the ability to see, okay, if I hit this here, what are the ripple effects? So when you look at pricing, it's going to show you issues with charge master. It's going to show you issues with your contracts, with payment posting, with all the aspects of your revenue cycle. The problem being is if you put blinders on, you won't recognize those things. So by all means, whenever you look at any area and everything we talk about here today, this isn't just about what you charge, it's about how we do it and how we represent things to the industry. Okay? So wherever possible, and this is a great check, okay, incorporate multiple fee schedules into your analysis wherever possible. So Medicare doesn't price everything, right? So there's a lot of things that they price incidental. Okay, which means that in the fee schedule, you get a status indicator and there'll be a 0 price next to it. Your commercial contracts, whether it's with Blue Cross, Aetna, United, whomever, may absolutely provide fee schedule amounts for those services. So one of the real important action steps is to go through and identify and obtain all of your available commercial contracts. When I go to hospitals, one of the hardest things for the hospital to provide me, even though they say they do this all the time, I say, that's terrific, let's get a look at the fee schedule. And they can't do it to save their lives. They don't have it. They don't know where it is. They don't know 4 CEOs had it before. So this is a great step. Take a second, go back, ask people, where are our commercial fee schedules? Because here's the fun thing. If you can't get the commercial fee schedules, how can the back-end office answer the question, did it pay appropriately? If I don't know what it's supposed to pay, all I'm assuming is that the insurance company isn't making a mistake. So it is very important as an action step to go out, grab those contracts, and then make a very specific decision about whether to include or whether to exclude the payer in your analysis. But wherever you can, include as many payers that you've got to, because you really want to start looking at payer mix, and you want to start analyzing and saying, how is this going to impact my customer base? You know, because we're looking at it department by department. So it's not going to be the same CT versus versus the ER versus the ambulatory infusion versus the ER. Okay, so very important step. So get those things, and if no one has the commercial contract, stop for a second and figure out why. Go get them. They're critical to your success. So when we get these things, and here's just a quick first table to say, you know what, this isn't we're not talking about launching the space shuttle here. Okay, we're looking at trying to get our data, list our charge master, and put some comparatives in place to be able to go through. So if you look at the document that's in front of you here, the column that is SI is the column that identifies whether it's a payable or it's a non-payable procedure code. And when it's a non-payable procedure code, there isn't anything in that APC payment rate. So just in a quick examination of this department, what this found is that from when we compared this versus APC, there was a range of 0.7 to 8.7. When we looked at it from Blue Cross, it was 0.24 to 4.5. And when we had another commercial multiplier put in, it was 0.33 to 2.24. You can see how there's tremendous variability in how your payers pay you and reimburse you. So we want to make sure that when we're making decisions about implementing a strategy, that we're using all of our available information. So when we go through with this and we say, okay, so now we've got this information and I've got Medicare here and I've looked and I said, you know what, I've got a good electronic version of Blue Cross and I've got a good version of Aetna. I'm going to combine and put these things in place, okay? So we start going and we start challenging our analysts or our people within our organization to really go through and put things into tables and really start stressing their Excel abilities, okay? So when we look at this, we want to make sure that we don't look at the hospital as one entity. We want to look at the hospital as a compilation of multiple departments and treat each department differently. So why do we want to do that? Because the costs aren't necessarily consistent across all of the departments, right? So your equipment and staffing needs are going to vary. The costs from one facility to the next are going to vary significantly. So a critical hospital with an ED, which may see 5 patients a day and staff 24/7, in spite of the low volume, is going to have a cost number associated with doing that versus maybe the same type of critical act, but they see 200 patients a day. So what we need to make sure of is that we adjust for our volume, but we keep our costs in mind. We want to balance things. So our action item is, department-specific multipliers when compared to the base fee schedule really does allow for a more consistent and representative comparison of services. So when you see that you're a very conservative priced organization, you may be looking at it and saying, man, this isn't allowing me to get reimbursement, which really maximizes my payer rates, but at the same time meets the needs viability for us, but also for what the customers need. So it's a very big step. And a lot of hospitals don't do this. They go, 5% across the board or 3% or whatever. And my worry is that when that happens, that hides and it perpetuates maybe a mistake that we made 2 years ago. And that just happens to be a mistake that gets used, 10,000 times a year. So think of things from a pricing standpoint, department to department. Okay? The reason why we want to do that is if you look at this, this is an example of a hospital that we just did very recently. Okay? And we took all of the departments, and we did exactly what we talked about. This is just Medicare only. Okay? And we came up with a department-by-department number and said, here's your minimum multiplier, here's your maximum for that department, and here's the average. What you can see is the tremendous variability, department to department, of what the pricings are set compared to Medicare. Okay? Right in the middle, I think that's 100 times. That was a mistake, right? They would have never caught it if they hadn't gone through this thing. Okay? Same thing. There's a whole bunch in that first column that are lower than Medicare. As a critical access hospital, we don't want to charge less than what Medicare will pay because it's screwing up our balance between cost to charge. So we want to go do this analysis and then research the individual charge codes where the multiplier is identified as a significant outlier, either high or low, in comparison to the departmental average. Because ultimately what we want to do is we want to bring everything in the department to the same multiplier times whatever, whether it's Blue Cross, Medicare, or commercial. Okay? So when we have significant outliers, they may be indicative of a fee error. So there's a fat finger by accident. We put a zero where there was supposed to be a decimal. Or we put, we instead of, $120, we put $12. Okay? That's a mistake. Okay? It happens because we're all trying to do 10,000 different things. Okay? Outliers can skew the averages that may result in overpriced or underpriced departmental averages. So all of a sudden, just think about this. If you make mistakes on, say, CT or MRI, where your patients are calling in and your customer service is looking things up and reviewing and saying, oh, well, we charge $1,287 for that. And that's a mistake, and they're like, wow, I can get that for $650 down the road. Thanks very much. They don't ever come back. Okay? So we want to review the outliers and reprice them if necessary to correct those errors. Not holding, not making everyone pay for sins for the past, but we've got to make it realistic for today. So we want to reestablish an average multiplier and apply the appropriate markup across the entire department. So if I decide I'm going to be 2 times Medicare, I'm going to lower some prices and I'm going to raise some prices, but I'm going to get it so that at this point in time, everything is at 2 times Medicare. Okay? And then you can decide, if you look at the entire institution, how that's going to impact gross revenue, and if you're really good, and you can actually project your net reimbursement by knowing, how things flow in ER, OBS, that type of stuff. Okay. So once we go through and do all of this, we need to understand what the contracts say. Okay. So we want to compare the fees to our commercial contracts, whether we use them as our multiplier base or not. We want to say, okay, so we're going to establish this. What does this mean in the world of Aetna, in the world of United? How do I go through the process of making sure that we're doing the things that we need to be doing? Okay? So identify and have a list of which commercial payers have lesser of language in their contract. What areas does this apply to in your hospital? Do they only apply the lesser of to the surgical department? Do they apply it to the other high-range items such as CT or MRI? How do they look at things from a pricing perspective for your ER? Is it a case rate? Is it variable? Is it percent of charge? When you're going through and looking at this, it is so valuable to take that information and create sort of a cheat sheet so that everyone knows what we're doing here. Because if we don't have that information, you have to ask, how do people on the back side of operations who are dealing with the remits and the payment advices and such like that, how do they know that things are paid appropriately? Some of us have software that we're doing adjudicating it. Last two hospitals that had the software that we're talking about, and we're looking at it, and they call it contract management software. The problem being is that the contract management software was loaded with the incorrect information. So the incorrect information was forcing people to look at things the wrong way. So surprise, surprise, it got loaded in with the wrong payers, and all of a sudden, all heck broke loose once they looked at that because they were being dramatically underpaid for a period of years. Okay, so just get it out there. Okay, figure out who is going to have, who's paying you on percentage of charge. Okay, likewise, in that contract language, you've got to make sure how do they control how you raise your fees? I'm capped at 3%. I'm capped at 5% a year. Okay, but what does that actually mean? Okay, so an action item is to review the commercial contracts to figure out when they're applying and saying you can't raise your prices by X percent, more than X percent per year, is that just a Blue Cross population? Is that on the fee from just, if it's Blue Cross, I'm changing it from $100 to $105, or is it based on the gross revenue from last year for Blue Cross for all of those services? Okay, you need to understand that. So as we start going, see, we're not talking about having blindfolders on here. When we start doing this, you're starting to get information that is critical to building your budgets. It's critical to providing good customer service. It's critical to being able to provide and make it so that your business office can be an opportunistic profit area because they're trying to examine to make sure that everything is right. And when that happens, we lower our overall production costs, and we end up having a more stable platform. So get those contracts. Okay? Compare them. Get a cheat sheet together that goes through and says all of the things that we need to be concerned about when we're setting our pricing methodology, and then don't keep it a secret. Hand it out to the people that need to worry about things. Get it to your business office leader to go through and say, how do I incorporate this into your procedures and policies? Okay? It's a very important step. Next piece, and this is a very good way to start stress testing your revenue cycle. Once I get all my charge master and I've incorporated, and my analyst is thrilled because she was able to merge and pivot the tables, and she put the APC in there next to the charge code, and she took Blue Cross and laid that over there, and we put the formulas in, and all. It's just tremendous. Now the next thing that we have to do is, that's great, but what you need to worry about is how often do I use these things? So getting the charge code level utilization is a critical component. Now again, with blindfolders taken off, this is the baseline for all of your revenue cycle reports for the departments. So if I'm CEO and CFO and I say, look, I need the utilization at the charge code level for the last 12 months, and I need it in an Excel file that I can go through and manipulate. Okay? I ask this of every client that I have. Half the clients have no problem. It's to me in minutes because it's part of their modus operandi. 35% of it, it takes days to get this information. And then the rest of it, this is the first time anyone's asked. And it's like, whoa. So this is a great stress test to go through. So what we want to do is we want to look at least 12 months, pull that information in, merge it into our tables so that we can absolutely see how often we're using these things. Because unfortunately, we never use the average price all the time. We always use it. If I made a mistake, instead of $850, I put it in at $85, you know that you've used that 12,000 times. Likewise, if you did something by accident and did it 19 times Medicare, you know that you use that every day under the sun, right? So this allows us to be realistic and say, okay, so how are we operating, and how are we using these items? The new price structure must make sense for each department. That's why we have to look at it a little bit differently. And we say, you know what, let's keep in mind our costs, let's keep in mind our utilization, and let's come up with a policy that makes sense for this department. We want to review the utilization data for potential charge issues or missing codes. Can't tell you how many times we go through it and they feel really good about it, and then there's 10 codes in the middle of CT that have no CPT assignment whatsoever, but boy, are we using those codes. So then you ask the question, guys, how did you price it and how is this going out to Blue Cross? They're not going to pay without a CPT, and that's when it gets very quiet in the room. So we want to make sure that we're using this to not only set our pricing, remember, take the blinders off, how are we using it, what mistakes are obvious based on the information, and they just fall off the page. You just got to make sure that you're looking for them and not just looking purely at a multiplier. Okay? We want to involve departmental leadership in the utilization review and final price structure. I don't need the department to set the price. I need them to understand how we price their things so that they can be good customer service advocates and explain things to our patients as they come through. Okay? So action step is a final review needs to be undertaken, right? So we need to pull that utilization data in, merge it into our ever-growing tables, because we're going to use these forever now, okay? We need to understand how we are contractually constrained about setting things and raising things, because there are going to be some departments that once you go through and you put the information into the steps, so a simple table like this, okay, my expectation is that if your department or your analyst or whoever's working for you can migrate data and get you something like this that shows the CPTs, it shows the charges, it shows me all of the, for this comparison we pulled APC in, but it can give me utilization by payer. That is a beautiful thing. And then I can take and say, you know what, here's my current gross revenue. If I changed it to a consistent 3 times APC, for this charge code, I'm going to go up. For this one, I'm going to go down. But all of a sudden, you're starting to go through and create a system that is based on evidence and data rather than just sort of letting it evolve and letting it happen, right? So likewise, we can shrink this thing down and say, you know what, I really want to focus in because according to my payer mix, my commercial guys in this department are, 40%. So let's look at what the results would be for my commercial payers. So all of a sudden, because I'm constrained contractually, that I can't go above 3%. So we can go through and say, oh, okay, so if I'm looking at these guys by themselves, and this is commercial, according to what I'm looking at, I'm going to increase that by 27%. Uh-oh, I can't do that. So I'm going to have some offsetting things in other departments so that I look at the average commercially so we can make sure that things balance. But all of a sudden, when you start looking at this, if I'm leadership at the hospital and they can provide me these pieces of information, I'm starting to feel like they've got better control of the process. I'm not necessarily working for the system. The system is now working for me, which is a hugely positive step. We want to make sure that we're not pushing things to the limit where we just kind of take things as we can take them. We want to go through and we want to pull the information that comes out of our billing system, our computers, whatever it might be, okay? And instead of just taking data points, we need to find out how we coordinate information. Because I'm telling you right now, these pieces right here, these are the genesis of your revenue cycle reports. Because if you can do this and get these tables together, there isn't any reason why you can't go through and say, you know what, we are going to make it a priority to make sure that all of our departments have accountability and ownership of their revenue cycle, their utilization, their charge master, all of that. I can provide the data points that are necessary to get it so that you can drive this. So my hope is that you'll take some of these tables and maybe give it to your analyst and say, you know what, can we create this? Can we get this information at this level? And they'll look at it, and if they can look at it, their immediate response isn't going to be no. They'll say, well, let me see how I can do that. We're going to have to maybe reprogram things to get some of the data headers a little bit different, but it gives them something very specific to look for. Okay, so one of the action items I would say is any of the tables that are in here, provide it to the people who are going through and are going to do this for you. Let them see this, feel it, touch it, and see if they can go through and they can implement it. So you notice that step number 1 wasn't go through and develop policies and procedures. The reason why this is a little bit farther down the process is because if we've gone through all of these steps, we now have a better appreciation and perspective about what it takes to go through and maintain and implement a pricing strategy. We also start to understand what we were good at in the past, what we weren't good at in the past. And if we look at the things that we weren't necessarily really proud of, we have to look at it and say, okay, so why was that? Could we then create a policy and procedure that, if written appropriately and supported by senior leadership to everyone as an expectation, could we eliminate these problems and then make it so that this isn't something that keeps me up at night? And ultimately the goal is to say, yes, we can do that. So why do we want the policies and procedures? We want to ensure that all future codes are priced consistently. You've just gone through a lot of pain and suffering to go through and fix things. What the bigger problem is that as we move forward, if we don't understand and set things appropriately, we could then create the problems moving forward all over again, and now it's Groundhog Day. Okay? So we want to make sure that we put these in place to ensure a healthy and accurate charge master. Better understanding of pricing allows for an educated and informed self-pay policy. So now when we go through and look at this and say, okay, we're creating our charge codes, how do I know that our self-pay policy is correct? Now you've got something that you can bounce back and forth and have perspective over. So once we go through and we publish these policies and procedures, it removes guesswork and provides support to staff. So a lot of times when I sit and talk to people, I get a lot of the shoulder, sure, I don't know. That's not my department. I have no idea how, the prices are set. And I ask them, who are you? I'm the charge master coordinator. Okay, so you don't know who controls the pricing. Well, I hand it off to this person who talks to this person, and then they just give me a fee. Okay? So there's no quality assurance in that. There's no way to, if you've got people who are responsible for putting these things in, to check and balance and make sure that things are done correctly. The other piece that this really allows is that, and everyone knows this, things come in to the charge master, but they never go out, right? A lot of times we always look forward, we never look backwards. So when we have this policy and procedure, it really forces us to be diligent and detail-oriented. So create a pricing policy that states that all new charge codes must be priced using the base fee schedule and department-accepted multiplier. Just create it. Put it right there. We've decided that we're going to use Medicare APC, and then for the CT department, we're going to be 4 times Medicare. For the ER, we're going to be 3 times. Ambulatory infusion, 3.5 times, whatever it might be. Get it written down, get it signed off by all of the leadership so that everyone's got skin in the game. Okay? Create a procedure outlining the steps for compliance to the policy. Then create a self-pay policy and procedure recognizing the established fees and acceptable payment structure for self-pay patients, including payment plans where applicable. Develop scripting responses for staff in advance of customer queries. So we'll talk about scripting in a second. But one of the things this allows you now to do is, if you're looking at things from the perspective of what's a good pricing policy, if I'm setting up from a self-pay perspective, if you've got, say, Blue Cross and Medicare into your document, and then you're looking at it and trying to say, okay, so we know that in this department, I charge 3 times Medicare. You can set your policy to say, okay, so if they pay up front, we can accept X as full payment, and you'll know that you're at least keeping consistent with either your Blue Cross schedule or Medicare or whatever, but there's thought that went into it. There's consistency. It's fair. It's not arbitrary. It's intentional. So all of this is now allowing you to take the steps moving forward with certainty as we start talking with our patients, as we start talking with our departments, as we start developing our budgets, if we're starting to look at new product development or deciding to bring these out reference labs. We want to buy the equipment. We want to bring this in-house. If we go through this whole process, it'll become evident very quickly given the payer mix and fee schedule constructs for that department, whether that is a smart thing, a good business decision that's going to add margin, or if there's something that we're going to just barely break even, but it's good for the community, or it's something we're going to lose our shirts on. So you can make this as an intentional decision. So all of these steps kind of leverage upon one another. The next step is really to start saying, okay, so now we've gone through a lot of the data work. Now we're starting to get into the personal work. So now we have to start figuring, okay, so we've done all of this work. I, as a CEO or CFO, feel tremendously good about where I am overall in this, in our journey here to develop our pricing strategy. So now the part that you can't forget or leave off is somebody's got to know enough to communicate this effectively to our patients, right? So we need to make sure, and a lot of hospitals don't even know who's talking to patients about this stuff. So we need to identify the staff responsible for providing fees and quotes for patients. Now, a lot of times this just isn't your financial counselor. Sometimes this is a knowledgeable departmental leader. This could be someone down in the surgery department. It could be a lot of different people that are involved in this. You've got to go through the process to make sure you identify everybody. You've got to make sure that if it's clinical staff who are asked, they frequently, they don't have the perspective or information to give appropriate answers. And that provides a great amount of stress to your staff because they don't want to tell somebody that's wrong. They don't want to overinflate, underinflate. They're in this gray area, which is not good either for them or your patient. Okay? So patient access to educated staff who are trained to provide accurate and consistent responses will provide quality customer service and strengthen the facility standing in the community because they're going to look at it and say, man, you guys are good at this. You nailed this. I call around all the time. I've got a $10,000 deductible. Nobody can give me prices, and when they do give me prices, I get the bill. It's always a different amount, so I have to call up yelling and screaming. But with you guys, you got it. You wrote everything down. You provided it. I got the bill, and oh my goodness, it was correct. You guys are awesome. They then become your biggest marketing device. They're your patient advocates in the community saying, you know what, go to that hospital. They're terrific. And, it's not only the clinical staff, but, man, I dealt with this financial counselor named Sandy. She was terrific. I explained that my husband just lost his job. She worked with me to nail it. She had access to all the information. So if you think about it, if you're designing your hospital right from the ground up, that's what you want, right? So action steps. So we want to educate clinical staff to refer questions to appropriate other staff, right? So the only way we can do that is we've got to understand who's talking to patients, what they're talking to patients about, and how can I help them be better every time. We want to educate and empower dedicated staff to address concerns, answer questions, and develop payment plans where appropriate. We want to combine the use of policy and people to create a culture of best practice customer service. Imagine that. We did all of this work to create policies and procedures, and I've got these wonderful, terrific, great advocates that are in my registration office, my financial, whatever it might be, and they empathize with the patients, but when they empathize with it, they're using a structure to make sure that everything's appropriate and then everyone follows through. That is a good thing to aim for. Likewise, people call in, and they have questions and whatever. It is important to create talking points for customer interaction. We can anticipate the majority of questions that are going to come through. We don't want people to answer them for the first time off the top of their head. Okay? Best practice is to go through, okay, and recognize that clinical staff need guidance. Financial advocates and customer service need tools to reduce stress. Stay on message and ensure, which is the most important piece here, a consistent and compliant process. So regardless of who you call in my hospital or who you talk with about the same question, I know you're going to get the same answer. Okay? So here's where a bunch of action steps where you really can go through and maybe put some stress to your organization to really figure out where they stand. Okay? So we want to create and provide talking points to clinical staff to ensure effective and clear communication. Okay? So talking points should do what? They should acknowledge the concern that the patient has. Okay? They're not calling to say, look, I have $8 trillion and it doesn't matter to me how much everything costs. I will write you a check today, right? No. They're calling to say, okay, so I'm concerned about this. I don't know if I can afford this. And in a lot of cases, with some of the smaller rural hospitals, they're making a decision on getting the care that they need and the service that they need based on how much it costs. And if we don't provide the right answer, sometimes they retract and say, you know what, I'll call back and reschedule. They never reschedule. So we need to do our duty to make sure that we've got everything priced appropriately, and then if there's a concern, we can acknowledge it, and we've got the ability to fix things proactively. Okay? We want to demonstrate empathy. If you have people that are on your customer service team that are kind of bullies or a bull in a china shop and just can't empathize with patients, they're in the wrong job. Okay? We need to find the right temperament. We need to find the right person to put in that seat. Okay? Because that is a tough job. We want to advise patients that they do not have access to pricing, but will refer to appropriate staff for review. So if I'm in, say, the radiology department and there's questions, they can absolutely say, look, that is not what I'm here for. I'm here to take care of you here, but I've got this other nice lady by the name of Sandy that you can talk to, and she can go over all of the pricing concerns. And then your tech has confidence that Sandy is just going to nail it and provide the best customer service that patient has ever received, so then everybody is raised up on that. We want to refer each patient to the department staff or counselor equipped to respond to concerns. Okay? So then if we don't lay this thing out, there's uncertainty about who to send this to or what question this is and where this should go, and then what ends up happening. We send the patient to the phone tree, and they get bounced all around the hospital, back and forth, and then they end up back where they started, and that's never a good conversation, right? So that's where we really tipped the scales and made the patient angry versus if we did this correct, this was an opportunity to shine. This was an opportunity for the business side of operations to leverage and increase the tremendous clinical quality that we're going to provide, and then we look at it and say, man, this hospital is the full package. I trust this. I'm going to bring my kids here. Versus the opposite. I hate the phone tree. It's like calling the bank. I'm done. Okay? We don't want to trying to get a pricing quote out of your organization like trying to set up a payment plan with the IRS. We don't need that. Let's not make it complicated. Let's think these things through and create the policies and procedures to make things easy. Okay? So we want to follow up to ensure that the customer concern is addressed. Ask yourself, we don't know how many people are ever calling in, but how do you know if you send it to Sandy that this got taken care of? Do you follow up to find out if they made the appointment? If they set up the payment plan, do you call Sandy and say, did Mrs. Smith get in touch with you? And if Mrs. Smith didn't, does she follow up with Mrs. Smith or have Sandy call Mrs. Smith. This is where you differentiate yourself from your competitors. Customer service is key, but part of it is that I understand in all these hospitals we're all wearing 10,000 hats. The problem being is if we don't wear the right hats and worry about the customer, there's not, all of a sudden our hat's going to start to decrease because we don't have as many patients anymore. So we want to do everything we can to protect and advocate for our patients. Okay. Another thing, provide talking points to customer service, financial counselors, and all others designated to respond to questions. Give them the script. We don't want them to talk like a robot, but we want them to have the talking points. We want to provide details to clearly explain pricing in a manner determined by management. What do we want to say? What do we not want to say? How do we want to say it? Okay? Go through and practice it with them. Have a period of time where maybe the CEO or the CFO or some other designee calls in and tries to go through and get a quote. Go through the process. See if they're following the script. See if they're empathizing with the situation. Kind of stress test and make it so that your staff never knows who's going to call, but it doesn't matter. I don't care if it's the CEO, the CFO, or one of our other patients. We treat them exactly the same. We give them the exact same information, and then we listen to them, and we make decisions about how best to ensure that they get the care that they need, but at the same time we protect the financial viability of the hospital and meet the patient's expectations. It's a lofty goal, but it is a worthwhile goal. We ask the patients if they have a health savings account. Maybe they've got flexible spending accounts or health safety accounts and offer to set up payment plans consistent with the deposits into their respective health savings accounts. You know, you get $237 biweekly, you know, and, you know, they may not even think about that. They're thinking of writing a check out of the things that, well, wait a minute. I could easily go through and give you a call on the 15th of every month to go through and just give you my HSA card number, and you could process that. That is awesome. I was thinking I was going to have to worry about writing you a check. But no, that's exactly why I have this account. That's genius. All of a sudden, that person is a superhero to that patient and that family. And we all know superheroes talked about a lot. So let's just try to go through and make sure that we get that type of communication from our patients. Okay. So finally, as we go through all of these things, okay, we don't want to go through and get into the process where we did all of this work and we fire and forget and never revisit. Okay. If you're going to go through the process of doing all of these steps and these action items and we feel good about things, we need to make sure that we routinely review and look back and re-examine and be not afraid to find out if we're doing things really well or if we're failing in some areas. Okay? So one of the areas absolutely is to review the charge master on a quarterly basis to ensure that the pricing methodology defined in the policy is being implemented and maintained. It's easy to do if we're going to pull these things into the table and say, okay, we're doing it by Medicare, APC. I'm going to compare these things against this thing, and all of a sudden you start using the same numerators and denominators, and all of a sudden here's some new codes, and we were supposed to be at 3 times Medicare, and then you start looking at it, and there's 5 new codes. They're all set at 4.66, 5.12, and here's one that's 0.38. So what happens here? You can head problems off in a very easy, in a very controlled step, but this has to be part of someone's job, that you set the expectation that on these dates we will download, merge, and run the analysis to see if we are consistent with our new code development. And then if we are, that's terrific. If we're not, go back and figure out why we weren't. What got in the way? Who do we hire somebody new and we forgot to explain to them? We had someone that went on an FMLA for 3 weeks, and we had someone fill in, and she didn't understand this, and yep, she made a mistake. Or we've got a policy where we don't put any decimals in. It's always ending in 00 for all of our prices, and this person did literal 3 times Medicare APC and ended up and looked, oh, it's 0.33, it's 0.38. We got to fix those. So I would rather fix 10 problems on a quarterly basis rather than fix maybe 400 problems on a yearly basis, right? So it gives you the opportunity, but that is consistency, and that is something that you need to make sure that there's an expectation from administration, okay? So we want to make sure that errors are not perpetuated. We want to document those issues and identify the root cause, all the way back to who actually did it. Your system absolutely will tell you who entered the code. Everything is nailed by their login, so you can tell exactly in most systems who put the price in, when they put it in, so you can try and figure out why that happened. And ultimately, it's even better when you go back to them and they pull out the file folder and they can go back to that day and they can look on their paper thing and say, oops, that is absolutely my mistake. Darn it, I usually go through and double check this. I clearly didn't that time. Okay? Or you go back and talk to them and they're like, yeah, I don't keep any paper records and I don't know. I have no idea how that happened. Probably the wrong person to be in charge of your pricing. Okay? The reviews also allow for periodic review of staff understanding and adherence to policy and procedure. Don't assume that just because you taught everybody once and went through this initiative that everyone's going to continue to do the things that they need to perpetuate the entire good stuff that you do. There's going to be, slaying. There's going to be times where they're overwhelmed. Well, let's just figure out and objectively look at it and say, what can we do? How can we do it better? Maybe we do every 6 months we do a refresher course, or that's on our registration staff and our financial counselors. There's a scripting session that goes through and we talk with them individually once a month or something like that. Fit it into the organization, fit it into the culture. It also allows us to look at the payer contract changes that may necessitate additional review, right? So all of a sudden you sign a new contract, what's the impact? If we're looking at this routinely, all of a sudden, if you know that you're going to sign a Blue Cross contract 6 months down the road here, you can do your due diligence and be ready and then figure out where you want to go, what your strategy is, and then be prepared. Rather than going into the conversation going, okay, well, this is the Blue Cross. We're going to take the short end of this one. You just know it. Why? You don't need to. You're patient advocates for your customers. There isn't any reason why you can't demand fair and appropriate pricing in the contract, right? So we want an action item, absolutely. Establish a consistent time period and format for quarterly pricing review. Have that go to the specific people as proof of where things are. I don't want to hear yes, that we're good, or no, that things are wrong. I want to see with my lion eyes. We want to complete the steps to identify the multipliers employed and review the outliers, right? So we want to correct any errors, reassert expectations if policies and procedures are not followed, and if changes are required to a department's multiplier because all of a sudden maybe costs have gotten out of whack or something like that, we want to remember to update the policy to reflect the new reality. Okay? So we always are trying to move forward with quality, detail, and customer focus in the future, in our eyes moving forward, but never forgetting that we are what we do. So we need to look backwards, make sure that we maintain things, make sure that we are in control. Okay? So hospitals that do this are in much better financial shape. We've got better appropriate AR. our adjustments are correct, our patients are happier, our departments feel more in control, the business office operates better. So it is a win across the spectrum. So I want to take a few minutes here, and Kim, I'm not sure if people have gone through and submitted any questions, but I think we have a couple minutes here and certainly want to address those if they've come through.
Yes, thank you so much, John. That was an excellent presentation. If anyone has any questions, it's *2 to unmute your phone line, or feel free to type a question into the chat box. There was one question, John. How do I convince my CEO or CFO that yearly across-the-board price increases